evening, everyone, and welcome to our PTSMC Wethersfield clinic. Thank you all for coming, and thank you to Casey and her team for having us. Tonight, I am excited to introduce and welcome our guest speakers for the evening. From UConn Health's Orthopedic and Sports Medicine Department, Dr. Kathy Coiner and Dr. Allison Schaefer. They will be speaking on the new UConn Women's Center for Motion and Performance. Please give a warm welcome to them both.
Well, we really appreciate it, and we will make this informal. And if you guys have questions, just raise your hands because we're here for you and really want to sort of explain. We really appreciate the opportunity. This has been super exciting for Dr. Schaefer and I, and just the ability to introduce the Women's Center for Motion and Performance. And we really want to try to elevate the care of musculoskeletal injuries in active women of all ages. And this is basically a virtual center. So as we talk about that, just keep this in mind. By no means do we have a big building, maybe one day, but right now it's just a virtual center, and we're targeting sort of this musculoskeletal injuries of active women of all ages. And we're very intentional to not just talk about athletes, right? So how this sort of came about, just to give you a little history of it, is I recently, I guess a year and a half ago, did a year-long leadership training that's very nationally well-known in academic medicine, and we had to have a capstone project. And this has really been in my passion and desire to do for a long time, but sometimes you just need something to put you over that edge to actually get something done. And ELAM is what this fellowship was called. And I had a cohort of other physicians, an ER doctor from Rochester, the chief of radiology at Ohio State, Columbia endocrinologist, Yale neurologist. So all these people, and they were all active, some of them even running marathons. And when I would talk about this, it took about, a month into it. They're like, yeah, but this isn't for us. This is for athletes. And when I didn't realize that when people talk about sports medicine, they think that we treat athletes. Now, granted, we would love to treat athletes all day, but that's not really our practices. It's the grandmothers with rotator cuff injuries, as you guys know better than anybody. So, this is very, very intentional, not just to talk about athletes, but instead active women of all ages. And that's super important. So please scan our little QR code here. We just made it. It's in a link tree. I don't even know what that was, but it has all our social media, our website, so you guys can sort of see what we're doing. And tonight, really, our goal is just to be able to introduce this to you, introduce the services we offer, and then ideally work with you to figure out how we can collaborate, because our ultimate goal is the same, and that's better patient care. Obviously, at UConn and UConn Health, we've always prioritized female athletes and obviously have built a legacy in women's basketball. But really less well known is our ability to care for those people that may not consider themselves athletes in the traditional sense. And, that can be somebody with knee arthritis or a bunion that's painful to, the young true athlete that tears their ACL. So we can really take care of all of that. And what we've done is sort of created this coordinated care model that integrates all of these subspecialties. And with the help of a nurse navigator, which I think is really, really key, and it's something different than orthopedics has traditionally had, but we are able to coordinate this care, and then the patients feel more supported and sort of help through that journey of whatever it is, whether it's running a marathon or triathlon or just, a couch to 5K, just trying to get more active because they've now had a baby and they want to lose some weight and continue to be active. So, and we're able to facilitate appointments. I'm always very honest, like probably too honest at times, but this has definitely made me a better doctor. Let's just put it out there. Orthopedic surgeons are very well known that, it's surgery or not surgery, and there's no gray in between. And I was definitely probably of that subscription previously. But now that I know where to send these patients, I know about you guys doing pelvic floor therapy for my hip patients that aren't getting better. And instead of just being frustrated with somebody that is overweight, now I have a resource for them to hopefully lose weight, to get rid of their hip pain or become a better surgical patient. So, every day that I think I initially was like, oh, this is a great way to market UConn Health, but now I actually believe in it. Mm-hmm. And I think that as a surgeon, I'm also giving better care. And I would say that, we haven't seen a ton of surgical volume. I think eventually it will come as we continue to build this, but, ultimately better care for our patients is important. So we really build it upon three different sort of pillars or focus mission. The first, which is what we sort of have hit the ground running with, is clinical care. The second is education. And, I came to UConn about 8 years ago, and one of passion of mine is being a female orthopedic surgeon is sort of mentoring the next generation. So I have a lot of high school outreach programs. Actually, I have one coming October 26th. If anybody has any high school age girls that are interested in medicine, the deadline actually closes at 7 p.m., so 15 minutes tonight. But we do it 3 times a year. So this session will actually educate our 900th high school students. So next one will break 1,000. So I think that's super important. And then ultimately our goal is to have sort of some more gender-specific research that's really lacking in the orthopedic and sports medicine literature and evidence-based medicine. So, our mission is really just to provide this comprehensive patient-centered care, treating musculoskeletal injuries of active women of all ages, and really leveraging our deep knowledge and honest passion. We were both former college basketball players, very washed up at this point. Yeah, very washed up at this point. But I think our passion remains the same. It's just to understand women. We were talking earlier about potty training, right? And I think, some providers don't always necessarily knows what it means with as females of having all these boundaries to taking care of ourselves, and I think it helps that we can relate to patients from that aspect. And our focus is really just preserving their motion and enhancing their performance. Whatever their goals are, we want to meet them where they are at and help them achieve whatever their goals are. We don't want everybody to run a marathon. That actually sounds miserable to me, but if you're in for that, then I'm help you do that. And it's really about their individual goals that we want to help. Obviously, you see the two of us, but more importantly than us are all the amazing group of people that we've sort of have collaborated with. And I think all of these really share the same passion and the motivation. You'll notice that there are a lot of women, but we do have men too. Dr. Corey Edgar, he specializes in patellofemoral instability, which is a very common female problem. Bob Orsiero has been around for generations, taking care of female UConn athletes. Zach Moss does our OMT out in the Stores Center. We have both male and female physical therapists, so we really span the gamut of things that we can offer. Kayla is our nurse navigator, and I think this is where it's been a little bit game-changing for us. So she's the central hub of both the coordination of appointments as well as patients feeling supported. And Dr. Schaefer will give a few examples of our fragmented care model prior to a nurse navigator and not sort of following through with patients. I print out a PT script and I tell them to come to you guys, and then, their story is you never called them, they actually never called you, they never got set up, they show back up in 6 weeks and they're exactly the same, but they haven't done anything. So now we have a touch point where Kayla can sort of figure that part out. This is a big win for us, I would say. We went live on April 23rd, and we've already completed almost 600 appointments. 161 of those are new, 436 are follow-up or injections, and they've seen 19 of our different members. So I think this is really successful. We have even 178 still scheduled that have not occurred yet. And you can see sort of here our monthly visit types. And, we wanted to make this a little bit educational, and I think this is sort of the why behind this center and, really reflecting and sort of trying to take action on health disparities and as health inequalities. We know they exist, and musculoskeletal encounters make up 130 million encounters annually. And women have twice as much prevalence of these musculoskeletal conditions, including, inflammatory arthropathies, osteoarthritis, ACL tears, concussions, patellofemoral instability, dequare veins, the list goes on and on. Also, we know that there's impact of gender views that as providers, we have preconceived views that sort of affect how we interact and engage and treat patients. Evidence shows that male patients have greater access to medical care as well as surgical interventions, even when the disease prevalence is greater in women. And this is a big one for us, that a majority of physicians, mainly surgeons, are also male, therefore sort of magnifying these biases. Orthopedics highlights this. We have the lowest subspecialty of women in the entire nation at less than 10%. But at UConn, we do have 3 female orthopedic surgeons that I think we can really are mentoring the next group of the generation below us. We've really taken that on head on, and we try to recruit and are out there to try to make a difference with this number. Female sex is a well-established risk factor for knee arthritis. Olga, in that last picture, she is our total joint arthroplasty in the Women's Center. And not only do they have a higher incidence of it, they actually have a greater disability when it's compared to men. But yet, when they see their primary care physician, they're less likely to be referred to a surgeon. And then when they see the surgeon, they're 4 times less likely to be offered surgery, even when you take the X-rays and sort of account for the disease progression. And then if you actually have a standardized patient, which we often do in medical school, and when orthopedic surgeons were given standardized patients, they are 22 times less likely to offer that female standardized patient, meaning they said all the same things, they had the same X-rays, but yet 22 times less likely to have surgery. And when these gender-based disparities in orthopedic access and utilization, they affect women more negatively in mainly every single group. So, the literature supports that we need to do better. And, it's always been our intuition that when patients feel supported and have some identity with their physicians and feel heard and understood, that they ultimately do better. And we're not saying that, men can't do that, but I think we just have a unique ability to sort of relate to some of these patients. And really, achieving this health equality requires recognizing the value of having unique differences in both anatomy, physiology, and experiences between men and women. And, the team we've really assembled has shared this passion and shared this understanding to ultimately collaborate better for the care of these patients. So I'll turn it over to Dr. Schaefer, and she'll sort of give us some examples to hopefully understand how it was and how we're moving into the future.
So I think it's sometimes easier to conceptualize what we're talking about when we talk about specific patient examples and how they would usually get treated, and then how they would get treated kind of moving through our center. So our first example will be a 38-year-old mother of a toddler with atraumatic right hip pain for about a year and a half, starting shortly after her child was born. So often, if this woman calls into our call center, she says that she has hip pain, and she's probably going to get scheduled right with Dr. Coiner because that's her specialty. And she might not have had any workup, any x-rays, any physical therapy, anything like that. So that first visit would really be Dr. Coiner saying, yep, you have hip pain. It seems like it's coming from your joint. Let's do some physical therapy. And yeah, maybe you need to lose a little bit of that postpartum weight. And then we'll see you back and we'll see how you're doing. And maybe they come back, they've done a little therapy, or they haven't, they get a hip injection. But, for many of these women, if you give them that physical therapy prescription and they can't get in right away, or they don't have that appointment when they leave, that's one more thing they have to remember. They're going to go home, their kid has a fever, they're going to be running around for the next week dealing with everything that goes with that, and they're going to kind of forget to take care of themselves. So this is one of the ways that we kind of want to be able to step in and intervene. So a different way that this has happened is now this same person, if she called directly to our Women's Center, she would get on the phone with Kayla, who is a nurse and has some medical training, and she would tell Kayla what's going on with her hip. And Kayla would realize that she hasn't had much treatment up until this point, so she probably doesn't need to see the surgeon yet. And she would probably get scheduled with me or one of the other nurse practitioners. One thing that we've started doing is we're actually giving PHQ-9, which is a screen for depression, and GAD-7, which is a screen for anxiety, to our patients. This is usually something that you would get once a year at your primary care provider, but we know there's such a link between mental health and how people recover from their injuries. And you guys probably see it every day when you're dealing with people. First visit, you probably know who's going to take twice as long as some other people to get better. But that's never something we've looked at. So right off the bat, I have a new piece of information that's going to give me a better starting point. And I think getting some orthopedic surgeons to give people depression screening and then talk to them about their depression, I've just been so proud, the primary care person in me, that we've been able to do that.
Just a quick story.
Yeah.
She's correct. I was like, really? I have to do this?
Yes,
Like,
you do.
Sure? But just the other day, I had, an athlete. Now, when they tore their ACL, I always knew that was going to be a really uncomfortable situation. I'm pretty good at it. I know how to sit down. I know how to read the room a little bit. But I never knew when there's tears and mom's crying because she also has this loss of identity of her daughter no longer being able to play sports. I would just change the subject and start going someplace else because that's the only thing I knew how to do. But now I think having the resources with having a sports psychologist who specializes in this, I now have an answer for that, and I have supported them better, and even about nutrition and things like that. So it definitely has improved my ability to care for people, even a little bit stretching my comfort zone.
Yeah. And I think so this person comes in, we do their screening forms, and they get their hip assessment, and it seems like the pain is, coming from their intra-articular hip joint. And then we also started talking, I realized, she's a year and a half postpartum. Let's ask some pelvic floor questions. Are you having any urinary continence? Are you having any pain? Things like that. And then the reason we're asking those questions is we're starting to figure out then who to send those patients to. Previously, I wouldn't know what to do with that information or where to go with them. So now we'll have extra.
I definitely wasn't asking that.
Yeah,
before.
she definitely wasn't. But now we know, and we have some questionnaires. So we have follow-up questionnaires to really start triaging people. So we give a diagnosis. We talk about the implication that weight does play on possible surgical intervention. And we go ahead and send her back to Kayla at the end of the visit. And Kayla schedules her an appointment for nutrition with physical therapy and with pelvic floor. So even some people that we work with in the community, if somebody knows where they want to go, we'll have Kayla on the phone, call the physical therapy office, and go ahead and get that ball rolling so the patient is set up. With nutrition, we have both internal medicine doctors that do weight loss and also a nutritionist that does non-diabetes nutrition, which is something that's often lacking. So Kayla is able to schedule into all of those slots so they don't have to wait for the nutrition team to call them. They leave with all of these appointments.
Yeah, that's a great point that I don't think we hit on. So what we have negotiated in all these different departments, because orthopedics is easy, right? We sort of have immediate control, and our chair is supportive of this. But we went to endocrinology and we said, hey, we need to have slots booked. When there's a stress fracture, they weren't getting in for 3 or 4 months. We need a slot in your schedule. We need a slot in nutrition. We need a slot in physical therapy. So that has really been a game changer for access for us.
Absolutely. And then one thing that Kayla does is she can follow up with people. She calls, but she also has a text, which is mostly what our patients want to use. And she will, check in with them. Are you going to physical therapy? Hey, we saw you missed an appointment. Hey, how's your exercise program going right now? So she can call this patient in a couple weeks and say, hey, did you make it to your appointments? How's stuff going? How are you feeling? So now when the patient comes back, she has gone to some pelvic floor therapy. Her urinary symptoms are improved. Her hip pain's improved, but not resolved. And then she just feels that she's having more energy due to some of these dietary changes that she's made with the nutrition. So she's in pain. She's still having trouble with her day-to-day life, taking care of her kids. So we do an injection at that visit, get an MRI ordered. And then when I see the MRI was performed, Kayla gives the patient a call to set up that MRI follow-up. She's lost 10 pounds of weight. The injection wore off, and we realized that, yes, she has a labral tear. She's a much better surgical candidate now. So then that follow-up is switched, and she might see Kathy here for the follow-up, just saving her that extra visit. I hate when patients come back, and all I'm saying is like, yeah, it looks torn. Go to the surgeon. Have a great day. I hate those visits. It's a waste of the patient's time to come down to that. So we're trying to cut down on some of those things. So another more kind of what we would think about traditional athlete, so 18-year-old runner with shin pain, previous history of a fifth metatarsal stress fracture. So I think one of the things that we see a lot is as soon as I have an 18-year-old runner with shin pain, I immediately assume they have a stress fracture until proven otherwise. And somebody with a history of a stress fracture, now we're coming into 2 possible ones at 18. I'm starting to go down all the rabbit holes of what's going on mental health-wise, eating disorder-wise. So usually what happens is you ask these patients and they kind of deny that they have any problems with eating. Maybe they say that they've been amenorrheic for 6 or 7 months. You're concerned about the stress fracture. You order the MRI, activity restrict, and physical therapy. And then what would happen is we would get an MRI back. It would show maybe a grade 4 stress injury, and we would recommend, you need nutrition, you need to see psychology, but we wouldn't have really great places to send these patients to. So same thing kind of happens now, but just the fact that we give those screening questionnaires to everybody kind of normalizes it. So when they come in before they even see me, they have to fill that out, and that's giving me that information that I need. We'll give the EAT 26 sometimes, which is an eating disorder questionnaire screening as well, which will sometimes give us more positives than the PHQ-9 and the GAD-7. We would still order an MRI and physical therapy for this person, but to me, a second stress injury within a couple years warrants an endocrinology workup for their bone health. So we would go ahead and make that appointment, which again, previously would take like 3 months to get in with. And then we have a psychologist we work with. Her main focus is disordered eating in athletes, which is a huge gap around here in our community. So we can directly schedule into her as well. So now this person is getting kind of this multidisciplinary care, which is what we do say with UConn athletics. Like if somebody's having a stress injury, they're plugged in with all of these people off the bat. So we're kind of trying to translate some of those care models.
With the sports psychologist, we hit a roadblock. So obviously I treat young athletes, she treats young athletes, and we're trying to send some of these ACL tears that we just mentioned to her, but because she's in the psychology of the adult UConn health, she couldn't see anybody over 18. But we met with her and we said, hey, look, like this is really a need, and they were able to figure it out. So now on a case-by-case basis, we can get other younger athletes in, which I think has been really helpful, but sort of just shows that collaboration that when we identify a need, we can hopefully find a solution for it.
And now for patients like this, with all of these other people on board, endocrinology, psychology, you can make a more firm diagnosis of something like relative energy deficiency syndrome. And they're able to help get us things like DEXAs to really get a good sense of the bone health of the patient. And this allows you to kind of reshape that expectations of when they're getting back to play. Any young athlete that you take out with a stress injury, because it's not surgical, it's like, oh, so 2 weeks and I'm getting back to it. And really being able to have those bigger conversations, so hopefully they don't get that third stress injury. I think I got one more. Yeah. So 52-year-old with atraumatic knee pain. She comes in and she just says, I feel like I'm falling apart, which is a common complaint we get. And I'm sure it's something you guys hear all the time. Hey, I'm here for my knee, but my shoulder's been bothering me. Do you think you could look at my big toe? That hurts as well. Also, my back's been hurting. You know, that's what we get when we leave the room. No, I'm talking about you right now.
I'm not 52.
So no, we got a few years for that. But I do think we see that complaint a lot of just like, I feel like I'm falling apart. So a lot of times, you know, we're very siloed. You're here for your knee. We're talking about your knee. So we get x-rays. We show some mild OA. And we give some physical therapy focusing on the knee, discuss kind of the diagnosis and encourage her to kind of stay active. And again, same kind of thoughts now. We're getting triaged by Kayla. We're getting all of our assessments. But at this point, if we have a 52-year-old who is overweight and they are complaining like they're feeling like they're falling apart, my next question's really been like, are you perimenopausal? Are you postmenopausal? Where are you in that? Because there's so much about that transition in life that causes musculoskeletal pain that has so little research, considering it happens to every single woman on the planet. Definitely something I hope that one day we'll be able to add to that research panel. But I think just asking those questions. So now one of our endocrinologists, her big focus is obesity medicine, PCOS, and she does a lot of hormone replacement therapy. So I've started sending some of these patients that are having a ton of menopausal symptoms to her to get looked at, like, do we need to do some hormone replacement therapy? And when that's happening, it's often helping their musculoskeletal pain a lot. So now they feel like they're not falling apart as much, they just have knee pain, which is so much easier to deal with than everything falling apart. So same thing, we kind of get them referred to all of these patients. And I think for a lot of these people, patients just listening to them and again, setting up these quick referrals so everything is done, they just feel much more supportive. Then if this patient goes, she sees physical therapy, she gets that baseline level of strength that she needs to start exercising, then I'll see those patients back sometimes. A lot of people just don't know what to do for exercise. If they've never been somebody who's grown up exercising, or say they were incredibly active at one point and they don't know how to translate that to their body in this new stage in life. I know, like, I'll struggle with that when I try to get in shape. I try to do what I did in college, and that just does not work anymore. I just get hurt, and then I'm out for like a month. So I think seeing them back and working on exercise prescriptions, something that we've been doing a lot more of in this.
When Dr. Schaefer told me she wanted to do that, I was like, you want to, what is that? Like, you're going to, that's a thing in medicine. So, I mean, she's taught me a lot about, and I think it's about our own professional satisfaction. I think by giving her the ability to do what she wants and what she enjoys, ultimately we take better care of patients. So exercise prescription is a thing. I now know that.
Yeah. It's a thing that sometimes I hate doing, but it's a good thing. I hate doing it because it takes forever. But it's, I think, a good thing, and patients like it, and it helps them kind of move into that next stage. And on that line, you know, I'm a primary care medicine doctor first, like I'm family medicine before my sports training. So there's a lot of stuff with primary care sports medicine that's not just non-operative orthopedic. So we're trying to translate that to some of our patients. I'll stop talking. That's enough.
So
is this me?
Yeah,
this is me too. So
I can,
So I'll do this one, then you can finish. So the patients that I think benefit most, what we're really trying to find are those patients who are really motivated. Obviously, we don't have unlimited resources in this center to have people. So really trying to get those patients that are kind of finally at that stage where they're ready to make that change in their life and take control of their health. People who have been previously active, and really it's got to be somebody with a musculoskeletal complaint that's keeping them from being active. One bit of confusion we've had are women just calling in that say like, well, I want to be active. And I don't have any musculoskeletal pain, but I have, I don't know, I have breast cancer and I need to be active. And you're like, does your knee hurt? No, I feel fine. It's like, that's not quite what we need. Like, it does have
maybe
to have
one
a
day, but not
musculoskeletal
right
complaint.
now. Yeah.
And again, although this isn't just about athletes, we do have the resources to help those people that are really looking for a higher level of athleticism.
And I think that's one thing that we can talk about maybe at the end with a discussion. And I saw on your flyer, you know, one of our gaps is that patient that's graduated from physical therapy and they still need some supervision. And, you know, that's where Kayla, she's had a lot of orthopedic surgery. She's had a lot of injuries. She's had a lot of surgery. She's active. She actually works out probably more than the two of us combined right now.
Absolutely.
So, you know, we've asked her to go out in the community. And I think that's one of the resources that maybe you guys can help us identify. But how do you get patients to us? You know, we have our own number, which is here, the 6330 number. She also has a cell phone. The orthopedic call center, which if anybody's ever dealt with the call center, it's not the best. Sorry, UConn. But they can transfer to Kayla, and then we can still get them situated. There's an online appointment request, and then physicians can refer to us directly. I think if you guys had the question, just call Kayla, and she would get patient scheduled or give the patients Kayla's number. So, you know, we really just want to be top of mind when you have these active patients that you need to send somewhere for this more collaborative type care. And we know that when patients hit roadblocks, they really lose momentum, and we want to support them, and we want them to sort of meet them where they're at and help them along their own personalized journey. Social media, we've been trying to do better with that. We have a podcast that you can go and take a listen to. Again, here's our QR code, and we've done video segments on Connecticut Live, as well as Great Day Connecticut. This is, you know, I say this is one of our early wins. This was at the Simsbury Half Marathon in June. We just opened in April, and we made this billboard. It was Dr. Schaefer's idea. At the top there, you can't really see it, but it says, "I am active because," and then people took a little name tag and came, and it was everything because they wanted to, you know, run a half marathon, or they want to eat tacos and drink beer. But this hangs in Kayla's office and reminds us every day, you know, sort of that why we're doing this, some funny reasons and some serious reasons. But I think this is sort of an early win that sort of reminds us every day. So we'll open up the floor for questions and see if you guys have any.